Session, let us see about the development of lung and the respiratory system. So in this development of the respiratory system, we have a gut tube which is divided into a foregut tube, a midgut tube and a hindgut tube. So this gut tube, it is derived from endoderm, and from the ventral part of the foregut tube this respiratory diverticulum arises. So this respiratory diverticulum, that is this one, is otherwise called as laryngotracheal diverticulum. And this respiratory diverticulum is found at fourth week of the intrauterine life. So this is the foregut tube. So initially you can see when the laryngotracheal diverticulum arises, here you can see that the foregut and the laryngotracheal diverticulum, they are continuous. This must be fused. So you know that the foregut will be developing into the esophagus and the laryngotracheal diverticulum will form the trachea. So to form an entirely different tube system, a separation must be formed here. So at first, at the junction of these two tubes, there is a foregut and the laryngotracheal diverticulum, a fold arises at here. That is a tracheoesophageal fold. So they will grow to the center and they will fuse along the length of the laryngotracheal diverticulum and they will form the tracheoesophageal septum. So after the formation of this septum, they will separate, and ventrally, you can see right here, ventrally it forms the trachea and the dorsally forms the esophagus. So this is happening in the initial phase of respiratory system development. Now we can see what are the derivatives of the laryngotracheal tube. So the mucous membrane and the lining epithelium of the alveoli, they are actually derived from endoderm because they are a derivative of the laryngotracheal diverticulum, which is a derivative of the foregut tube. And the muscles, cartilage and the fibroareolar stroma, otherwise the connective tissue. So these components of the trachea and the lungs, so they are derived from the visceral mesoderm. Visceral mesoderm, which is surrounding the foregut. So the derivative of the laryngotracheal diverticulum is the larynx. We have the trachea. This is the bronchus and the lungs. So discussing into detail, at first the larynx. So the larynx has got an epithelium, the cartilage and the muscles, and about its nerve supply. So the epithelium, it is derived from endoderm. So the cartilage and the muscles, they are derived from the fourth and the sixth arch of the pharyngeal arch. So this is the fourth and the sixth pharyngeal arch. So this pharyngeal arch is one of the most important topic, and I will be dealing in another video. So from the cartilage component of the fourth arch, we have the thyroid, epiglottis and cuneiform. Cuneiform formed from the fourth arch, and the cricoid, arytenoid and corniculate. So these are derived from the cartilage component of the sixth arch. So you can remember like this, from the fourth arch there is tech, that is thyroid, epiglottis and the cuneiform. That means 4. It is derived from fourth arch. Now talking its nerve supply, the structures derived from the fourth arch, they will get its nerve supply from superior laryngeal nerve of vagus, which is the nerve of fourth arch, whereas the derivatives of the sixth arch, it gets its nerve supply from recurrent laryngeal nerve of vagus. So now about trachea. So the epithelium, as I have already mentioned, that it is derived from endoderm, and we have the muscles, cartilage, and the areolar stroma, which are derived from the visceral mesoderm, or visceral. It is otherwise called as splanchnic. Splanchnic means visceral. Splanchnic mesoderm. So next is the development of the bronchus. Do you know that the right lung is having the 3 lobe and the left lung is having 2 lobes? So the development of the bronchial bud, two bronchial bud, as you can see right here, that is a primary bronchial bud arises. So by the end of fifth week, the right bronchial bud, it divides into 3 buds. So this will form 3 bud, and the left bronchial bud will divide into 2 bud. So that means we have 3 lobar bronchi on right side and 2 lobar bronchi on left side. So in the maturation of lungs, we are having 4 stages. So initially, the these two bronchial buds will be invaginating into the splanchnopleuric layer of pleuromic coelom. So actually this splanchnopleuric layer of pleuromic coelom, this splanchnopleuric layer will form the pulmonary pleura. That is the visceral pleura. So these two buds will be invaginating into the coelomic cavity. They will be invaginating into the coelomic cavity, and it is this splanchnopleuric layer which is closely investing the pulmonary pleura, which is investing the bud to form the pulmonary pleura. So the lung maturation is happening in 4 stages. The first is the pseudoglandular stage, second is the canalicular period, third is the terminal sac period, and fourth is the alveolar period. So the first stage, that is the pseudoglandular period, it is occurring between 5 to 16 weeks. So in this period, you can see that this is the respiratory tract, and the proximal portion, the cuboidal cells will be, tall columnar cells will be developing, and the distal part, the cuboidal cells will be formed. So altogether, when you are looking at the developing lung, it looks like a tubulo-alveolar gland, but it is actually a pseudo-glandular. So that's why this stage is called as the pseudo-glandular stage. And the mesenchyme around here will give the cartilage, the muscles, and the fibroareolar stroma. So the second stage is the canalicular period, which is extending from 16 to 26 weeks. So in the canalicular period, the lungs become more vascular, and in this stage there will be the differentiation of cells into type 1 pneumocyte, and the cells which are not getting differentiated becomes the type 2 pneumocyte. It is this type 2 pneumocyte that is producing the surfactant. This surfactant, it is a phospholipid rich fluid which reduces the surface tension of alveoli. So in the canalicular stage, each terminal bronchiole, it divides into two or more respiratory bronchiole, which in turn divides into 3 to 6 alveolar duct. It should be noted that in the pseudoglandular period, there is no formation of the respiratory bronchiole or the alveoli. Only up to terminal bronchiole is formed. So actually there are 17 generations or the subdivisions. That is, for an example, the trachea, it divides to bronchus, it divides to bronchioles, and it ends by becoming the terminal bronchiole, respiratory bronchiole, and finally the alveoli. So this generation will be dealt in a physiology video about the respiratory system. So the third stage is known as the terminal sac period, that is extending from 26 week to birth. So at the terminal stage, there is formation of the blood-air barrier. So in this stage, the epithelium gets thinned out and there is perfect gas exchange. So the terminal sac means the primitive alveoli. And the fourth stage is the alveolar stage, extend from 8th month to childhood. So here you can see that in the terminal sac stage and the alveolar stage, there is an overlap. That is 26 week to birth is the terminal sac stage, whereas the alveolar stage is 8 month to childhood. That is, it can extend even up to 8 years. It is because the alveolar stage is occurring simultaneously with the terminal sac stage. So in the alveolar period, for the efficient exchange of gases, the alveoli, there are three things that is occurring in this alveolar period. The alveoli must secrete the surfactant. The second thing is that the lung should transform from the secretory phase to the gas exchange phase. And the third thing is to establishment of the pulmonary and the systemic circulation. So these are the prerequisite for efficient gas exchange. So for the release of the surfactant from the type 2 pneumocyte, we have the lung fibroblast. This lung fibroblast will release a factor, that is fibroblast pneumocyte factor. Fibroblast pneumocyte factor. So this factor, it will go and act on the type 2 pneumocyte to release the surfactant. And you can see that the surfactants are released. So this is happening at the 7th month. So the 7th month can be considered as the viable age. So if a premature baby is found, that is, the mother is provided with certain steroids, corticosteroids, and through the mother it reaches to the fetus and it stimulates the fibroblast pneumocyte factor to release surfactant. So this is a table which I have taken from the Langman's medical embryology. So now going on to its applied aspect. The respiratory defects are seen associated with a group of anomalies which are called bacterial. So the bacterial includes the vertebral anomaly, the anal atresia, cardiac defects, then the tracheoesophageal fistula, esophageal atresia, renal anomalies, and limb defect. So the next defect is the hyaline membrane disease, otherwise called as respiratory distress syndrome. So this is a most common cause. This is a common cause of death in the premature infant. Actually, in this case, the surfactant is reduced. That is, either there is deficiency or there is no surfactant. So this survival, it is essential for the survival of premature infant. So here you can see this is the alveoli. This is the air and here is the blood. So during inspiration, the alveoli increase in size because air is getting filled. And during expiration, the alveoli reduce its size due to air is expelled out. So actually, the surfactant, it will reduce the surface tension to prevent the collapse of the alveoli. To prevent collapse, surfactant will play a very important role. So if the surfactant is deficient, there is no production of there is no surfactant, so the surface tension will rise and during expiration the alveoli gets collapsed. So why is this called as hyaline membrane disease? It is because this partially collapsed alveoli, it contains a fluid. So this is that fluid. It contains a fluid with a high protein content, many hyaline membranes, and there is also lamellar bodies. Lamellar bodies. So this probably derived from the surfactant layer. So that's why it is called as hyaline membrane disease. So the treatment for the respiratory distress syndrome are, for the preterm babies, we can give artificial surfactant. Artificial surfactant. And if the mother with a premature labor, we can give the cortisol. So the cortisol will stimulate the surfactant production and it have reduced the mortality associated with the respiratory distress syndrome. So supernumerary lobe means in your right lung you are having 3 lobe. So instead of 3 lobe you will get a 4 lobe, and in your left lung you will get 3 lobes. So they are supernumerary lobes. In this context I would like to explain about the Azagas lobe and the lobe of Azagas vein. So Azagas lobe, it is simply the increase in the number of lobe. So in this diagram you can see that normally the Azagas vein, arch of Azagas, you mark in the mediastinal surface of right lung. Okay. Sometimes you can see that the Azagos vein, it arches over the apical lobe of the lung, so that a portion of the apical lobe you can see right here that lies medial to the Azagas vein. So this lobe which is lying medial to the Azagas vein can be called as Azagas lobe. So this is actually the lobe of Azagas vein. So the next developmental anomaly is the tracheoesophageal fistula. There are actually 5 types: A, type A, B, C, D, E. So earlier I have described about the tracheoesophageal septum. So due to the abnormality in partitioning of the esophagus and the trachea by the tracheoesophageal septum, it results in the tracheoesophageal fistula. Fistula means abnormal connections. Actually, there will be esophageal atresia. Esophageal atresia with or without the development of tracheoesophageal fistula. I'll show in the diagram. So in this type you can see that there is no abnormal connections, right? So this is there is esophageal atresia. Here you can see there is esophageal atresia. This is the esophagus and this is the trachea. So atresia means there is no opening here, it is closed. Okay. So in this condition you can see that the proximal part of the esophagus, it is communicating with the trachea, whereas the distal end, it is not communicating with the trachea. So this can be called as proximal fistula. So in this type you can see that the distal part of the esophagus, it is communicating with the trachea, whereas the proximal part end as a blind sac. So in this type you can see that the esophagus, it is communicating through two channels with the trachea. But whereas in this type you can see that these the esophagus is communicating to the trachea through a common channel, and it is like an H shape. That's why it is also called as H type. The most common abnormality is of this type and is 90%, seen in 90%. That is the upper part of the esophagus ending as a blind pouch, and the lower part of the esophagus forming the tracheoesophageal fistula. These two types are seen in 4% of cases, whereas these two types are seen very less, that is 1% of cases. So in the larynx, I would like to add one more point, that at the time when the cartilages are formed, so this is a epithelium of the larynx. So this laryngeal epithelium will proliferate rapidly. It just proliferates rapidly, and it just occlude the lumen, as you can see right here. Then what happens is that, so there is a temporary occlusion. Then what happens is that subsequently a vacuole will develop, vacuolization, and the recanalization, new canals will be formed. So this will actually produce a pair of lateral recesses in the laryngeal ventricle. So this space is called the laryngeal ventricle. So these recesses are bound by, so these are the recesses. So these recesses are bound by a fold of tissue, and that will differentiate to form the vocal fold. So that fold of tissue that differentiate into, this is the false vocal cord and this is the true vocal cord. So this is that space, the laryngeal ventricle. So winding about, we have talked about the tracheoesophageal septum formation and the laryngotracheal diverticulum contributing to the respiratory system. Then about the stages of the maturation of lungs. Then about the various defects. So thank you for watching.